Thank you, Dr. Fawad. You're an excellent teacher, my teacher, and also an inspiration for all of us. And I'm back again with another interesting case, this time TAVI, a bumpy ride. So, 70 years of age, male patient with a BMI of 24. He had a history of coarctation of aorta, surgical repair in 2020, now presented with symptomatic severe stage D aortic stenosis, NYHA class 3, moderate to high surgical risk. Patient had a baseline EKG of atrial fibrillation, left bundle branch block with a QRS of 125, non-obstructive coronary arteries. Heart team decided for TAVI. So on transthoracic analysis, it was a bicuspid aortic valve, P gradient of 68, mean 41, area of 0.7, EF of 25 to 30%, a dilated LV, pulmonary artery systolic pressure of 35. On CT analysis, adequate femorals, about 7 or more than 7, coronary height and sinus of Valsalva height and diameter were also adequate. Annulus mean diameter was 26, perimeter was 82. So this is the CT analysis. As you can see here, can you run the second presentation that I've uploaded it? This is an old presentation. No, the previous one, I've given you another in a USB. Anyhow, so it was a bicuspid aortic valve, Siever's type 1 with a fused, yeah, this one, thank you. As you can see lower down, it was a Siever's type 1 with the calcified raphe and the calcified commissure, so already a complex case. Annulus was 26 with a minor axis of 25, LVOT was 28, and intercommercial distance was 28, kind of a tubular anatomy that we were lucky in that case. You can see on the left side the quark. You can appreciate the quark. We weren't able to really appreciate and measure our graft from the CT scan, and we decided to go fluoro for that. The axis was fine. The root was a bit dilated and a bit angled 56, but it was okay. So as you can already see, 26, we decided for the valve of 34, and we decided for a pre-dilatation of this valve, heavily calcified valve with a 25 balloon. So usual technique that we use, ultrasound-guided micropuncture access. We took the angiogram of the quark. You can really appreciate the bend in the quark. It was, the minimum diameter was 7.7 millimeters. So our first problem was that will we be able to cross our valve through this graft? So to test that, we took a Lunderquist wire and we crossed our delivery system without the valve, and it went nicely. This is the cusp overlap, coplanar view, and then we cross LV with the, this is a straight tip wire and with the cross LV with the AL1 with the straight tip, and then exchange it with the Lunderquist wire. Before pre-dilation, that is a norm that we always check for the valve, adequate loading of the valve, because in this case, patient might go into severe AI, so we should be ready with our valve, and we should so that it can be deployed relatively quickly. So Lunderquist wire in the LV, we changed our strategy a bit. we pre-dilated it with 23 mm balloon, and it slipped a couple of times. You can also appreciate the calcium at the aortic valve. It is clearly heavily calcified. It yielded. We upgraded our balloon with the 25 mm balloon because we weren't satisfied with the previous result. We were afraid that our valve might pop up. So we know that we would be increasing the risk of stroke, but we decided for dilating our valve with the 25 balloon. So this is a nice image, excellent image. You can see our 34 mm evolute R valve traversing through the graft, nice and easy, with the help of the Lunderquist wire. Now, the third problem was that though we aimed for a little bit higher deployment, but this you can see is a lower deployment. Because lower deployment, so we recaptured it. The second deployment was a bit higher, and there was a risk of pop-up, so we recaptured it, and we decided this for us, this depth was okay for us, so we decided that we will go a little lower and deploy our valve a little lower, but to prevent the pop-up. So as you can see, the valve is almost circular, opened nicely. So we released our valve, and it is an excellently open valve, no constraint, no deformity, cone is okay, no PVL, trace AI, so excellent result. So the peripherals were okay. Interestingly, and most importantly, there is a trace AI. His LV improved immediately from, it was 25% from the baseline and improved to 40%. The mean gradient was 7. So post-procedure, though there was no vascular complication, the patient had the same atrial fibrillation, left bundle branch block, there was no AV block. But as the patient had a baseline AFib, we went excessive with the pre-dilation. Patient had a subacute ischemic stroke the next day, but it was a moderate neurological dysfunction, mild weakness in the right upper limb that was improved on the third day, and we discharged the patient on the third day on anticoagulation. So the patient on follow-up, even after 2 months of follow-up, patient had complete resolution of his weakness. So this case, I looked up into the literature. There had never been such a case reported that they went across the valve through the graft. There have been cases of simultaneous coarctation of aorta repair with the stenting and then performing the TAVI. So I'm open to discussion.
So I think that was a wonderful case and a wonderful demonstration. Just a question, I mean, we all know it was a case of bicuspid aortic valve with a concomitant coarctation of aorta. Now, considering the morphology of the valve, it's always going to be more ellipsoid as opposed to being circular, the valve. So is there any consideration that is given in terms of valve selection and also sizing up? And what are the recommendations? So
basically, majorly for valve sizing, we use annulus measurement, average annulus measurement, perimeter drive valve sizing. And also depends upon the anatomy, if it's tubular, tubular, it is tapered, it is funneled. So majorly with there was a recent article that showed that if you size your valve based on the annulus, the virtual annulus plane, then you have an 88% success of appropriate valve success. Another important point that you have raised an important point. So you have to consider things like intercommissural distance, you have to consider the length of the raphe, and you have to consider the calcium that is involving. So in my case, it was a heavily calcified valve with both the commissures and the raphe. and the raphe length was 14. So we might have undersized our valve, but we decided that we would go for an extra dilation. So we'd open up, because our anatomy was tubular, our intercommissural distance was same, our valve annulus was almost same, and alveoli was same. So the perimeter was 82, it was well under 34 mm valve, annulus was more than 26. So in sizing, it's an important point. If you're sizing your bicuspid valve, sizing your valve in a bicuspid anatomy is different as compared to trileaflet valve. We have to consider these things.
Thank you. So I would request Dr. Ali to elaborate that.
Before Ali, because I think the questions will also be answered by Ali. A very good case, Dr. Qasim, but did you calculate the calcium score of the aortic valve on the CT scan?
No, we didn't, and it's now relatively obsolete to calculate the CT calcium score. We already knew that patient had a severe symptomatic AS. We could use CT calcium score in diagnosing, in helping a diagnosis of AS, but now it's been obsolete to use a CT calcium score.
I don't think it is obsolete, because actually this is one of the best method to find out the from the calcium score. You can find out about the severity of the aortic stenosis. And the other thing is that why do you use CT to define the annulus rather than go for the echo, and where on the parasternal long axis you can see the diameter of the LVOT? Why do you do the CT?
For TAVR valve sizing, it is recommended to go for a CT analysis. Dr. Ali Raza, expert from PIC, would like to answer that question.
What sir has mentioned is
just a minute.
Ji, sir.
Your patient post-TAVI implantation, you got atrial fibrillation?
It was baseline AFib. Patient had a baseline AFib with left bundle branch block.
At the baseline?
Yeah.
And then the left bundle branch block?
It was also at the baseline with a QRS of 125.
Already there.
Already
so
there.
in such a situation, would you find that the ejection fraction improves in these patients?
Sir,
it may take some time, not immediately.
So you raised actually very good points in there, but that what it does that I will try to save our fellow from there. So,
thank you.
Other the cases we done in ICVDs, but so a couple of points. Calcium scoring has to be done there in a sense that it gives you a rough idea, and there is going to be a trial coming up for the stroke prevention, and you will see. I'm not supposed to disclose, but I will tell you that there is a calcium score in there that it predicts the stroke rate of it, because so far we do not have any strokes. So what sir meant is this: it's an excellent thing for diagnosis, but also to predict that you have got a lot of calcium there. A couple of other things which were there is your balloon was and the length wasn't big enough. Yeah. And I think it was a 30 millimeter length.
It was a 40 mm. 40 that was available in the inventory. We should,
so that's one thing. And the second thing is this, that you should have paced it much more rapidly.
It was 110, paced 110. So should have been paced at 180.
So you should pace it rapidly, and it will prevent the balloon from slipping. Yeah. The second thing is this, that what is my suggestion is that I don't upgrade the balloon, because you cannot open this raphe. So this raphe is not going to open, and you whatever ballooning you did, just be happy with it. You have made the space and go with the stent after that. The sir's point is about the annulus measurement. Yes, you can use also echoes to measure, but you need an experience like that for that. Not with my eyes experience, actually. So if your echo is as good as sir does his, so you can use it. Yes, it can give you, what we do is that it gives us the measurements of the aorta and how it is going, and we can see the femoral, so we usually do according to that technique. So, and Linderquist wire, I might have used a Confida in this one as well, and I might not have used, because you had to position, so you had to push on the wire, and the Linderquist has got tendency to go through the LV because it's a little bit more stiffer. but I'm sure the rest of the points all raised were. Actually, that is a very important question. It's not absolute, and you still can use it.
Okay.
So.
I think calcium scoring as such wouldn't really make a difference in terms of management decision once you have a severe AS, which is severe and symptomatic.
Yes, sir.
It do helps in you pseudo AS or false AS where a gradient, you are in gray areas.
I don't mean, sir, for diagnosis. I mean that.
Yeah, for sake of prediction.
Prediction of the stroke. Yes, but these are all things which adds to make your procedure easy. So you pick up everything, I would say.
But here it's apparent severe calcium. Yes, so you expect anything what you expect with a severe calcified lesion. I agree with that. You have in a gray area certainly.
Stroke risk would have been very high in this patient. Don't balloon twice. It has happened to me in my early days. In future, if you guys are doing it, don't balloon it twice.
That's a pertinent point.
Just a couple of points. As Dr. Qureshi has said, endless measurement by echo and the calcium scoring. I think
when we talk about the calcium score on the CT scan,
it
is the basic evaluation. When you are doing a CT scan, you must do this calcium scoring also. Another important point, Ali, you would also be looking at the takeoff of the aorta, how it is aligned, because if it is vertical, you have it easier to implant the valve. Otherwise, if it is horizontal, it is going to be difficult.
That's why I said that I would have used the wire in order to push and pull, and that's the point which sir said is that horizontality of this aorta affects it, and obviously these are like a lot of technical issues in it, but then you did a very wonderful case and you should be applauded for this case. But it is right that you check everything in this, and the horizontality, verticality, all these things matter in this.
Thank you, Dr. Ali Raza. On your point about the Lundquist wire, the usual practice here at NICVD is that whenever we use a 34 mm valve, we use it, we cross our valve with we use a Lundquist wire. And obviously, if there is a tortuosity, extreme tortuosity, abdominal aortic tortuosity, we use a Lundquist wire. So it's a usual practice. Might be different from at PIC, might be different from NICVD and other centers.
What Dr. Shabazz Qureshi was saying, that endless measurement should be a routine on echo. And then when you are doing the CT, you obviously do that again. So we do not miss anything. And similarly, CT calcium score is a routine thing. Another thing about the coag, the gradient was
we cannot listen
it's
you,
more
sir.
of a tortuosity of the vessel. And that's why it was, for the coarctation, it was, gradient was very less. It was more of a tortuous aorta. Had you, I don't think I have seen anybody crossing more than 40-50 gradient with the valve. So,
okay, great case, Qasim.
Thank you very much, and good learning point on the CT calcium score. Thank you, Dr. Ali. Thank you, Dr. Fawad.
Okay, let's move on to the next case. Why an apparently optimal PTMC fails. Dr. Mariam Masood from Fauji Foundation Hospital, Peshawar. Why an apparently optimal PTMC fails.
Assalamu alaikum everyone, this is Dr. Mariam, and I'm going to present somewhat basic and simple case today.